of the co-responders program, the impact team, the restorative justice effort that's under development, and also the citywide mediation program that's being rolled out. So I think we kind of have it lined up in Cynthia. Oh, you know, Ryan or Cynthia, can you share your screen, or does Ryan need to enable that? I can't tell.
I should be able to, but I think that Reed is going to start us off. Let me double check that this is enabled. So can you guys see this slide?
Yes.
Yeah. Okay. So we are ready to go, although I don't think you need to look at the front of the slide while Reed is potentially talking. So if it's okay, I'll turn it over to Sergeant McGrath to do a little bit of an overview.
That's great.
Thanks, Cynthia, and wow, you get to see my radio face twice here. This is kind of scary.
You want me to keep it up or take it down?
It's fine. You get to see our co-responders in action. I think that's really what this is about. So I want to thank everybody for being here tonight and for working with us on moving forward in policing in 2021 and beyond. So first thing I'm going to do is turn this over to Shauna Flores Lipa for a minute. She's going to talk about a couple of experiences with co-responders. She's a detective now, but she was a patrol officer last year and the year before working here. And so she's going to tell just a couple of brief stories. And then as Joe Anderson asked, I'm going to talk about the kind of the inception and building of the co-responder program. And then Cynthia really has the all of the data and the details in the presentation tonight regarding the co-responder program and some alternative policing models with it. So Shauna?
Hey there. So originally when I was on patrol, I had some experiences working with Heather, who no longer is a co-responder, but she was great. I had the luxury of being able to work a specific call that kind of stands out for me, where she went with me to a runaway. And he was a 13, 14-year-old boy who was in the middle of a mental crisis. And we were able to contact him at a friend's house, and he was refusing to go to school. So the great part about it is that we were able to work with him and mom and get him services with mom, but we also found out that he had a lot of childhood trauma, and that Heather was able to work with mom because she was a single mom. She was going through a hard time making ends meet, and she wasn't able to be there the way she wanted to be. So she was able to do that. Heather was able to follow up with her at a later date and give her those resources, which was super important. Also, as police officers, we only get 30 minutes to an hour to really work with people to get them solutions. And we were lucky that Heather was there because she was able to do something further because, with that boy's long history of mental health issues and his childhood trauma, he was going to need more than the 30 minutes or the hour that I could really offer him. And then I also have a personal story. So I also have a teenage boy who is, he's in high school. When he was about 15, 16, I thought he was just going through the hormonal changes and just being a typical boy. He started to withdraw and he would say weird things. And there was times where like some of the flags would come up and I was afraid I was being like the kind of psychotic helicopter mom, and I didn't want to be that. So I actually reached out to Heather through text. I was like, hey, this is what's going on. And she was able to offer our family resources for him, which was super helpful. And then it helped, so not only is she helping Englewood City as a community, but she was helping the police community as well.
Thanks, Shauna. And Heather's the one in the middle of every picture here. She somehow ended up in the middle, and she moved on to Jefferson Center, got a kind of a more unique job there, but did a great job with us. And she's a local person, grew up in Greenwood Village, and so we miss her. The co-responder program here kind of started informally in about 2017. We had just a few hours here and there, and it was hit and miss, and it was kind of a little bit more missing than hitting. And Cynthia and the director of All Health and I met with a couple of people. I think Chief Collins was in that meeting and talked about how can we move this forward. And in 2018, we started the co-responder program, completely funded by the Office of Behavioral Health. If I refer to it again, I'll probably say OBH, and Cynthia will too, because that's what we call it. But they funded the program 18 hours a week, and it was very successful and very well received, to the point that the department decided in 2019 to up it to 40 hours a week, and we began paying for the balance in hours there. I'm sorry, I think we went up to 60 hours that year. We did a nice increase. And then in 2020, council approached the chief and said, we'd like to increase this program more and fund it more. So in 2020, what we have is we have 80 hours a week of clinician time, and everybody we have right now is a licensed clinician. They all happen to be licensed professional counselors, LPCs, but LCSWs are certainly welcome in the program too. We just don't currently have one. For 2021, we have a request for proposal that should be going out in the next week or two. We have a competitor that wants to bid, so we have to open it up for bidding. So we'll be looking at that, and we're not exactly sure where we're going next year, but we have some good ideas. There's been some, well, I wanted to just point out, I guess, that our co-responder program is probably the most robust one in the metropolitan area and in the state. It may seem like, wow, it's really small, but keep in mind that we only have about 35,000 citizens, and with 2 full-time equivalent clinicians, that's a lot. I was talking to a Lakewood agent who's a friend of mine last Friday, and she said they have 2 co-responders in the department, and they've been unable to fill one of the positions, so they're functioning with one. And y'all know Lakewood is considerably bigger city, considerably bigger department. And we've kind of looked at Denver has a number of co-responders, but compared to their population, we're really have a really robust program and are able to cover 80 hours a week, which is really a pretty substantial amount of coverage. What we are doing here is a little bit different than some other programs. You're going to hear about some Denver programs and stuff. Those are funded through different means. This is funded entirely by the city with some supplementation from OBH. OBH did cut some funding this year, but All Health was able to boost the funding of that program up a little bit. So we're not seeing any substantial impacts from there, but I think the statewide budget issues resulted in OBH cutting some money. If anybody has any questions about that, Cynthia would be the subject matter expert on that. But our funding is stable because it's a city priority. It's a city budgeted item, and it remains a priority for the police department. And certainly Deputy Chief Sam Watson can talk about this, but I know from Chief Collins that this is a high priority for him to maintain this program and keep it going. So unlike some other programs that have foundation funding, grant funding, things that tend to come and go, this is a stable program, and we're really happy for that. Cynthia and I have been meeting quite a bit recently. For 2021, we're really re-envisioning where the program's going to go. She's going to talk about that quite a bit, and we certainly have some ideas and want some input. So Cynthia's an absolute expert in many areas and has put together this presentation, which is outstanding. So thank you, Cynthia. And again, thank you for being here tonight.
Yep. Great. Thanks, Reed. John, I had initially asked for about 15 to 20. I'll just say to the group, I'm not going to be able to get through this in 15 to 20. I think it would be a disservice in lieu of the importance of the agenda item when we're talking about alternative policing. So if you guys can bear with me, and if anybody's getting really impatient with the content I'm covering, then just give me the cue. Okay. So what I'm going to do is I'm going to walk you through some of the details about the current program that we have. Then I'm going to compare it to the STAR program out of the city of Denver, which a lot of people have questions about. And then what I have are summary documents, summary material based on all of the different options that are out there for alternative policing models that involve co-responders, including program outcomes and what we know and what we don't know from some of the research. And then at the very end, I'm going to talk about some of the challenges and some of the recommendations that Reed and I are leaning towards. So the model that we have at Englewood is what's called an embedded co-response, which is what all of you know. This is where a licensed clinician rides along with a police officer. As Reed mentioned, we have 2 licensed clinicians that work 80 hours a week, and you can see the hours when we have coverage. There are also what's called secondary response, that is case management that's done out of our office at All Health, covers a minimum of 8 hours a week, where that person can do follow-up with either CIT referrals that come in electronically or follow-up that's needed from the co-responder work. We provide all the leadership and supervision, program development, program evaluation. I'm going to show you some of the data that we have that are collected out of the different data systems that we have. We obviously, as a health entity, have to maintain a health record. And so we have the ability to be able to dig in with every individual that we have in contact with, to determine if they're already connected with services, what their diagnosis may be, things that are very important for the clinician who's on scene. We do some training for the officers, not just with Shauna and her son, but in general, being able to be available as a resource, and some formal hours. The current cost to Englewood includes, the cost is essentially for those 2 licensed clinicians, including their benefits. And then we have an offset that covers 16 hours a week total. That's 30 grand. So the Office of Behavioral Health has dramatically cut funding of all co-responder programs. I'm going to talk a little bit about why that has happened and where that money is going. But that's very much a reality of co-responder programs. It's something that we have to pay attention to. So in 2019, we had a total of 810 referrals. That's pretty high volume for a co-responder program, as you heard Reed mention. To date, when we last pulled the data, since today is the 30th, I didn't have September data. We're tracking at 634. We had a little bit of a blip during the start of COVID, but otherwise we're back on track. You can see in particular, we've increased the number of clients that we're able to treat in place. And I apologize, you all may call them citizens or individuals, but you're going to hear me say clients, and that's just how it works in our world. But about 56% of the time, if a co-responder is involved, then we're able to treat them in place, which is a big win for everybody. We see an average of 3 referrals a day. They average about 25 minutes on the scene. And then in particular, the number that's extremely important is 73.1%. What that means is that 73% of the time when a co-responder or a case manager is in touch with, has a touch with an individual that we have in contact, that the likelihood that we're going to get them into some sort of treatment after that intervention is very high. So that's one of the key metrics when you're looking at co-responder programs and how effective they are. We really want to know not just are they intervening on the scene, because while that is important, that's reactive during a crisis. We want to be able to try and prevent that person from calling again. And we want to make sure that they get connected to the services that they need, not just an evaluation in the moment for a mental health emergency, but also that they're actually getting connected to care. So this is a breakdown of the different types of referrals that we get. And this is from the 2019 annual report. So that was sent out in the shared drive. That one had been in there a little bit longer, so some of you guys might have seen this. The primary reason why a co-responder will go out on a call is because of a welfare check. You can see we do have some that are doing homeless outreach, but out of that, what did we have? 2019, we had 810. 100 of them were classified as something with homeless outreach. Oftentimes people will jump into a different category. So we may come on the scene thinking it's because of a homeless situation, and it turns into a mental health evaluation. The other thing that is worth taking a peek at is what happens after they get involved. You heard me mention about that 56% that are treated in place. We do still work with getting people transferred to an emergency department. There are times when that's medically needed, or if they have substances on board that we know can't be handled in another setting, then they're about a quarter of the time someone does wind up being transferred to an emergency department. One thing I should mention about that, though, is that for when an individual is transferred to an emergency department by a clinician, compared to by a police officer, the likelihood that they're going to be admitted to an inpatient psychiatric unit goes down by 150%, which is pretty significant. And what that is that there's so much collateral that's provided that the emergency department actually can get them moved through the system faster. That warm handoff time period in the emergency department is quicker if a co-responder is involved. And so the flat number of 26% is one thing to look at, but I also just want to call attention to the fact that it actually helps people get to the right place, helps them move through the system a little bit faster when a co-responder, a clinician, facilitates that. For those of you who aren't familiar, the WIC is a walk-in crisis center. So All Health operates the walk-in crisis center that covers the city of Englewood. The next closest walk-in crisis center is in Aurora over by the Anschutz campus. And so All Health covers quite a large territory. A walk-in crisis center is open 24 hours a day. It's staffed by licensed clinicians and a rent-a-cop with no weapon. The door is not locked. And so it is a very small percentage of people who actually can be brought to a walk-in center. However, 16% is actually pretty good. And so the fact that co-responders can find a way to be able to bring someone to the walk-in center, even though I'm not going to talk a whole lot about cost savings from a community perspective, when an individual goes to an emergency department, the minimum average cost is $2,500. When someone goes to the walk-in center, the general cost, because there's not a lot of fluctuation, is $500. So there's some thought about being able to get payers involved, Medicaid in particular, to help them see about offsetting some of this work, because we are ultimately saving Medicaid a lot of money. We're not necessarily saving the police department money because they still have to transport somebody, co-responder still involved, but we're saving Medicaid and payers money. Amy had asked at the last meeting to be able to have some information about arrests. I don't know if that was specific to the co-responder, but I felt like that it was worth digging in. So we did pull data and find that in 2019, there were 10 clients that we interacted with that while the co-responder was involved, it resulted in arrest. That is a very consistent national figure with co-responder programs. And so when a co-responder is involved, the likelihood of any sort of arrest is very low. And we have seen that with our data here. Detox, as you guys know, is a huge void in our community. It has been ever since the closure of Arapahoe House. Detox is quite a ways away for someone to transport. And so that really doesn't happen very often through our co-responders. So if you can take a look at this information, I wanted to do some comparative analysis to show you what's happening on a monthly basis with All Health Network co-responder program. So the number of referrals, the age breakdown, what we're doing and what that's looking like just as of recently. And then in particular, whether or not the person is already in services. Co-responder programs that are rooted in the community and part of the behavioral health system in that community are really key to be able to make sure that you have high success with getting people connected to care. This next slide, though, is one of the, we had a whole bunch of data that was shared by the STAR program through Mental Health Center of Denver. It's been getting a lot of press. The STAR program is modeled off of the CAHOOTS model in Oregon. And if you look at these numbers, I just wanted to share that the volume and the work that's happening in Englewood is actually higher than what the STAR program is doing. The STAR program is funded in large part based on a foundation that was established, as well as tax dollars, grant funds that the Mental Health Center of Denver was able to get with the city of Denver. It is staffed by a paramedic and a licensed clinician. I believe there is one licensed clinician. And in particular, if you look at what is happening in these programs, they're very different. And in particular, look at the homeless numbers. So 69% of all STAR program participants are homeless. And although they don't track that as the reason for the call, we know that most of their calls are related to not just a welfare check, but a trespassing charge that law enforcement is not getting involved in. I would say that in many of those cases, you probably don't need a paramedic. You probably don't need a licensed clinician to intervene with someone when the real reason why they're out there on the call is because they're homeless. We do have some involvement with people who are experiencing homelessness, but it's a small percentage of the work that's happening. So I felt like that this was important. MHCD has an other category that I can't dig into a whole lot because I don't have access to their data, but you can see 27% of the time there's something else going on. And again, the last item about whether or not the person is placed on a hold is another good indicator that this isn't really a mental health co-responder program. It is a homeless outreach program that also has mental health services available. So I just wanted to be able to point that out. We might have some questions about that later, but I felt like that this information was important to share with the group. The other thing I'm going to do, and I'm going to try and, well, actually, I'm going to leave it here if it's okay. We have a data dashboard that was built, and we filter this based on which law enforcement entity needs access. So there are, it's called Power BI, and this allows us to track and allows for the designated person at each law enforcement entity to be able to have access to data to track what's happening on any given month. I'm not in, this is a screenshot of the dashboard, but it's an interactive dashboard. So if we were to click just on August, then I can break it down and show you exactly what happened in August and for each month. This is one of the things that is built into our contract to be able to deliver this kind of information so that whether it's Mayor Olson or the chief, whoever needs information to be able to understand what's happening, then this can be tracked. There are 3 different screens. This is a second one that tells a little bit about the demographic breakdown, including the payer source, which is important because we do try and bill payers whenever we can. And so, and I can tell you that I have data, I think later on a slide, but when we're able to bill Medicaid, we get reimbursed 98% of the time. So if we can get Medicaid data on clients, we can bill for it, and then that helps offset some of our costs. One of the challenges that we have is over here with race data, and you guys might have heard me mention this in another meeting. We have a lot of people where we either they're not sharing their race or we're not asking. And I don't know which of those 2 categories we're falling into, but that's an action item that our team is working on. The last screen tells you a little bit more of some of the disposition that I showed you before. It also, the charts down here on the bottom show a little bit of trend as far as what the population looks like with who we're seeing. Are they already connected to services? Did we have a failure to be able to connect with them? That's that yellow line all the way on the bottom, which you can see stays pretty flat, especially since March. We have a better time reaching people post-COVID. Most people are picking up their phones or they're at their door, but we only have about a 3% rate where we're not or is that 5? Maybe 5% where we're not able to reach people when we try and do follow-up. Yeah, we can come back to the data and I can open Power BI if we need to. But that is sort of the general overview of our program. Before I move on to talking about different models, I want to pause and see if there's specific questions about our program that either Reed or I can answer.
I think Amy's got her hand up.
Hi, thanks for the pause. I have 2 questions. I think it was either slide 3 or 4 about the type of responses, like home, welfare check, suicidality. Are those mutually exclusive in the sense that some of these are co-occurring things happening at the same time? Like how are they marked individually?
Yep, they are. They have to be in order for the count because we want it to match with the number of clients served. So what they do is they select the primary reason for the call.
So those are primary reasons. Okay, because that's actually important to distinguish, right? Because
yes,
they get you can respond to multiple things. So the other is, so I just want to check. So the STAR program is zero intercept program, like there's no police going out? Because, sorry, I probably could have read that more carefully. Do you know? Because a paramedic, and then I think you said another worker.
My understanding, and Reed, if you know more from some of the other materials that have come in, please jump in. My understanding is that the program is being dispatched potentially, by police. And so it's very possible after police have been on scene, then they're determining. So what would you,
Yeah, they will divert calls to them when they're in service directly. They have a protocol for that. And also officers are able to request them to respond.
Okay, thank you.
Yeah, I was gonna just chime in there real quick. The 911 dispatch will defer directly to STAR, and then as Reed mentioned, officers can also then request them after the fact if the officers are there on the scene first. But the primary goal of STAR is to divert 911 calls, fresh 911 calls, directly to the mental health and EMS team, as opposed to involving police from the outset.
I think we've got Joe and Guillermo lined up next.
Thanks for that, Cynthia. My question is, if well, maybe Reed would have a better idea of this. Is what was those whatever percent, I don't remember the numbers of calls that were either ending up at the crisis center or dealt with in place. What was happening on those kind of calls before we had the co-responder program? Were people ending up in jail more often because of that, or was there more emergency room visits? Just trying to figure out what we've changed since we've got this program in place.
I think as a department, we've for a long time had our officers CIT trained, crisis intervention teams. We are a little bit behind on that right now with COVID and just trying to work through the economy, keeping people hired, but probably somewhere between 70 and 80% of our officers are consistently CIT trained. And ideally, I know we've had times we've reached even 90-some%. That program tends to encourage jail diversion as it is. So I think we've been conscious of that as a department for years. Certainly this program improves our ability to not arrest people and get them into alternate treatment programs. But I would say most likely the percentage of people going to the ER, that 16% that you see go to the WIC, probably 12 to 14% of those would have gone to the ER. Some of them would have been left. And many of the treated in place would have gone to the ER as well. The clinicians are better able to, as licensed professionals, to develop crisis plans for people to work through resources and to avoid ER visits for what would otherwise be just moderate suicidology. Something that really probably doesn't need to go, but as an officer, they may not be comfortable leaving someone at home.
Okay, thank you.
Guillermo, did you have one?
Yeah, Cynthia, you mentioned the data like on race was still something that you guys were working on in the system. So will you be expanding from the categories that are there for Asian or Hispanic?
So what I meant by that was that it's not being collected. So the most common racial category here is unknown. And the reason for that is something that we're addressing actually systemically across our organization. I don't know if the staff member isn't asking or if the individual is refusing to answer. Asian is a category. It doesn't show up in this because it was 0. So anything that is 0 doesn't show up, but it is a category.
And in regards to age demographic data, do you have the numbers broken down even further between 18 to 65? Just knowing that there's almost 3 different generations in that span?
Yeah, we do. I don't have it offhand, but we have client level data on all of this. And so anything can be broken down even further.
Okay, thank you.
Yep.
I think that's it for this round.
Okay. All right. So let's talk about all of the alternatives, because one of the things that I think we run into is we only know what we know, and we know what we have. And then we also know the STAR program or the STAR is a type of CAHOOTS program. One of the documents that I sent to you all, I put numbers on it because there were 50 different programs. And I thought, most of the time we're talking about 2, and it's important to understand the context that there's so many different options. So I wanted to make sure we're all on the same page, that generally speaking, when we're talking about alternative policing, we're talking about being able to get people, to divert people in crisis away from the justice and the emergency department, to be able to get them actually connected to services. So we don't want law enforcement serving as social workers. We want social workers, case managers, licensed clinicians being able to do that work. From the research literature on CIT International co-responder program goals, this is taken straight from the text from the Vera Institute, that there are a lot of different goals. And many of these are focused on mental health. And that has been the focus of our co-responder program. Our co-responder program, while we do address homelessness, has been focused on addressing mental health and substance use crises. So in addition to being able to reduce ED visits, hospitalizations, arrests, what we're also talking about is being able to provide a community service that really helps, it does help reduce costs to payers, but in particular, this is something that can actually be a boom for the community to know that this is available. So whether you're a parent who's in need of a service, and if you call and request a CIT officer, if you get a co-responder on the scene, this actually has a very strong impact on the reputation of law enforcement when there are co-responder programs. The documents I sent through also had a definition of a crisis-related call for service. So just wanted to be clear again on what we're talking about. We're talking about having some sort of call that comes through that's due to mental health, substance use, and then in particular, the literature also identifies the homeless situation. So there are 3, I guess I should ask, and I can't see everyone, but I sent a lot of materials about the different programs. Did some folks have a chance to skim those to get a sense? Okay. So there are 3 categories of different programs, and you heard Amy mention the intercepts, and so some of these are at different intercepts. And I will tell you that I am more familiar with the logistics of some of these programs as opposed to the intercept models, so I'm just going to talk about the programs. There are outreach programs that are really designed for what's considered intercept zero or pre-crisis. This is a proactive approach to be able to try and prevent 911 calls from happening. There are interventions at the 911 level. So there are programs that are designed to be able to determine what happens when someone calls 911 in crisis. And then there are programs that happen that involve a first responder of some sort. And there's all different types of meanings when we talk about first responder. So one of the things that is important to consider is that we could be talking about interventions, programs, and recommendations that are made pre-crisis to try and prevent the calls from happening in the first place. We can talk about recommendations once somebody calls 911, or we can talk about interventions after someone calls 911. So if everybody's with me, I'm going to give you a couple of things that are important to keep in mind. Criminal justice literature shows us, and this is sort of to piggyback on the conversations that we've been having around use of force, that situational factors such as demeanor, hostility, and impairment explain the most of the variation in the use of force by police officers. In particular, officers with CIT training are less likely to use force as the subject's demeanor becomes more resistant than non-CIT officers. So regardless of which program we're talking about, I just really need to hit home the importance of CIT training for officers, because that alone is one of the most effective of any program. And there's actually, the only efficacy study that's been done to date that has statistically significant findings around co-responder programs or any of these different models are those that involve CIT trained officers. I had a really good conversation with one of the authors of this paper, Dr. Amy Watson, who is also the president of CIT International. She gave me some of these resources. We had a really good conversation about the lack of research, because I knew that was something that the group was smart enough to understand, to ask for. There's a real shortage of being able to compare one program to the next. To a certain extent, they all work. And they work because of, you know, anecdotal experiences, because of the reports of law enforcement, because of the experience of the individual. They save costs, they keep people out of emergency departments. Those are the ways that they work. But there isn't a study that compares one to the other. But I do have some outcome data that I'll show you. All right, so the pre-crisis programs, these are the outreach programs. And in the materials that I gave you, there are multiple programs listed under each one. This is a high level sort of one sentence summary, because I know we're not going to take all night going through this. So specialized outreach is typically, it's typically folks that are in plain clothes, which is important because that's different. Oftentimes the programs are plainclothes officers, especially when we're talking about a CIT program, and they connect with people who are homeless and do essentially case management to get them connected to services. Paired outreach is when you take an officer and a mental health professional, or perhaps a case manager, so maybe it's not a licensed person, but it's a case manager, and they do outreach to individuals to be able to get them connected to service. A lot of the paired outreach programs don't just do homelessness. They also do folks that are living with serious mental illness or have a substance use disorder. So those are very common with the two. But again, this isn't a reaction to calling 911. These are known people in the community that have high needs, that might need law enforcement presence when a case manager or a licensed clinician is going out to meet with them. On the other side, there are also entire teams that are built around being able to do outreach that involve law enforcement, usually a licensed clinician and a case manager or a peer. Peer models are getting a lot of traction nationally, both because they cost less and because what they're finding, a peer navigator is someone who has specialized training, and yet they have a lived experience. They have previously been homeless. They have previously interacted with law enforcement. They may have a mental health condition or a prior substance use disorder. They're getting specialized supervision around how to balance that work, and they can be part of this team as well. So that model is getting a lot of traction, especially in the state of Colorado. So just want to give folks a heads up about that. So you can see all of these models. You can have just the officer going out. You can have the officer and a clinician, the officer and a case manager, a peer. You can add to this group to decide who you want to target, but this is all done pre-crisis. The next layer of programs that we have is intervention at the 911 level. And these programs are struggling to get off the ground in the state of Colorado. There have been multiple meetings. We got an email today from the head of the Rocky Mountain Crisis Hotline, who she said they've been trying to get this going since 2012. So you have a model, the first model on the left, where you can have a dispatcher who's actually trained in mental health, that they can do some of that crisis work on the line and they can take the call directly. You can have a situation where you put a licensed clinician in the 911 center in the PSAP to be able to take the call themselves. So that's one model. Or the model that we're really moving to in the state of Colorado is that you can have a system that funnels at the 911 level that would transfer the call directly to a crisis hotline. In the state of Colorado, we have the Colorado Crisis Hotline. There have been fits and starts with pilots to be able to do this in the county of Denver. They had a pilot that just died a week ago. I was hoping to be able to tell you that this is happening, but it just died because the crisis hotline didn't have the staff, which really meant they didn't have the funding to be able to have this diversion go through. There are a lot of different protocols and requirements for each of the different PSAPs, the public safety answering points for where the 911 calls come in. I will tell you that the city of Chicago does this. So there are definitely models that have figured out how to be able to get calls transferred to a crisis line. The 988 law, that legislation that recently passed through Congress, you guys might have heard about that. That does essentially, it's going to mandate that this will be something that happens, that people can call 911 or they can call 988, and 988 is for mental health. We're a few years away before that's going to happen. And one idea is that there could actually be a more aggressive pilot through Englewood to be able to see about having that split so that then an officer doesn't get dispatched, but it goes through the crisis hotline. And I'll circle back to that in just a minute. The next and the type of program that you guys are probably most familiar with are interventions by a first responder. So you can have essentially only CIT officers that go out. So that's that specialized response that we do know is an efficacious model. We know that we get good outcomes when we use CIT officers. There are some counties that only have designated CIT officers, that's all they do. Other times it's that they're integrated. And I would say sometimes it's hard to hire a police officer to only do these types of calls. And so staffing is something to keep in mind with that. The middle embedded co-response, that's what we have, the partnership between All Health Network and Englewood. This is also the model that's used in Boulder County, the EDGE program, which you guys might have heard of. That's early diversion, get engaged. That's also an embedded. This is when you have a team where it's an officer and a clinician. They usually have a paired response that the two of them will go and ride along to the event. I will tell you that we have, Englewood is one of 6 law enforcement entities that we have co-responder program. And one of the co-responder programs that we work with, our co-responders are in their own car. And so they're actually in a car that's provided by law enforcement. And so they get dispatched directly when law enforcement is on the scene. That's because they cover a larger territory. And so it doesn't make as much sense to have an officer paired directly with a one-to-one co-responder. So instead the co-responder gets dispatched, but that's still considered an embedded co-response. There's a lot of creativity in different programs of how these look. And then the last one on here is the mobile response. And by mobile, I don't mean cell phone. This is the STAR program. This is Cahoots, where they are in their own mobile vehicle with their team. And in this case, it's often a medical responder and a clinician, and they get dispatched directly to be able to go out. Grady EMS in Atlanta started piloting this years ago. There's a number of models that have been using the mobile response. Virtual is something that I talked to Reed about, I don't know, a year and a half ago, because we had someone who approached us that they wanted to be able to put iPads in the hands of the officer, so that then the officer who's on the scene would connect via a teleconference like we're doing right now with a clinician back at our office. So that's another, it's still considered in the same category of mobile or virtual response. Those models aren't taking off very well, but that is, I wanted to make sure you all know that there are a lot of different opportunities for this.
It's Cynthia.
All right. Yes.
Before you go on, Mike has it, or he had his hand raised. I don't know if it was relevant to where you were, but Mike, do you have something?
Yeah, thank you. Just a quick question just about our program. So our program is the embedded co-response. It fits into that category, but I guess question for maybe Cynthia and probably for Reed. Am I correct in observing that functionally our co-responders in Englewood sometimes participate in some of that proactive outreach as well, that first category that we talked about, specifically kind of the dual outreach with officers?
Yeah, so we have done that with the Platte River cleanup. And so there was sort of a specific event, but as a general rule of thumb, no, they're not doing that. Reed, is that correct?
We are trying to do more. The COVID thing really put a damper on everything we were doing. We were doing some more outreach into the schools. All the schools have a lot of programs. We found out that when a kid walks into the middle school or high school office and says, I'm suicidal, the school resource officer gets called. And so the better resource is always a clinician to be able to intervene in this situation and direct it. So we were looking at that. We do on occasion do some. It would be my goal to do more. We just talked about that in an impact staff meeting today about how we can get out and do some more. But COVID really changed the way we do things for a while, and we really want to do more. And Cynthia and I are having really big conversations about how can we take this program and turn it into a more proactive program.
Yeah, I can say personally, I've had really good experiences just participating in some of that outreach, and having the co-responders present during those events has been really beneficial. So that could be something we could discuss after your presentation, maybe looking into some of those more proactive approaches.
Yep. And we'll cover that a little bit in the recommendations. And Mike, correct me if I'm wrong, but you're involved with Change the Trend, correct?
Yes.
Yeah, so one of the things that just for the rest of the group to know is that our organization does provide care navigators at places like Giving Heart or Graceful Cafe in Littleton. So that's something that has been arranged outside of the co-responder program, again, kind of as a pilot to see what they need. But those are very, in a sense, controlled settings. Like, you know that everybody's going to congregate, so we can have them go there at a set time. Whereas when I think of the outreach programs that I just described, it is more about, you know, I think we need to go see John Smith today, right? And so a little bit different than waiting for someone who's homeless who might be coming in for a meal, as opposed to being able to say, these are some high utilizers, frequent callers that we need to really outreach.
Mhm.
So,
Thank you. That's helpful.
okay. Okay. So,
Sorry, Cynthia, it looks like John's got his hand up too.
sure.
Thank you so much. I really appreciate what you were saying about the CIT program, or CIT training, I guess is more accurate, and about the kind of combined programs that you're suggesting here, the mixing and matching of what's right for Englewood. I do have to hop off pretty soon, so I just wanted to get a couple things out there real quick before I have to hop off. I'm really interested in expanding CIT, which I think is what you were suggesting already. I'm really interested in expanding the current co-responder program, and I'm really interested in what you're talking about, 988. I think that those are all really great concepts. And one thing that I want to make sure of is that we don't kind of make too narrow a scope in what we're trying to achieve. Having been homeless for half a decade myself, mostly through my youth, I cared deeply about the homeless population in Englewood, but I don't want this to be only about homeless folks either. I want this to be about, you know, the entire community, and make sure that what we're doing is addressing mental health concerns, and not even necessarily mental health, but crises, right? Emotional and mental crises that may be a moment in time that are better handled by your folks, Cynthia, than, you know, having a police officer go over there who, number one, that they're not then focusing on, you know, preventing or investigating or pursuing crime that's happening, but also, you know, they're probably not the best equipped for it either. Can you tell me, I don't know if you have numbers on what the response times are for co-responders?
Well, the co-responders that are embedded go when the 911 call comes out. So it's
Gotcha.
essentially the same response time as law
Officers.
enforcement response. Yes.
Gotcha. Okay, cool.
Now,
and then, I'm sorry, go ahead.
well, I am going to talk a little bit, and I'll have John send out the slides afterwards, because I wasn't sure if you were going to be able to see them, John. So I want to make sure. I am going to talk a little bit about another crisis program called SAFI.
Okay.
That has, they do mental health crisis response. They are intended and contractually required to be a resource to law enforcement. But one of the barriers to that, and it's funded by a completely different stream, and it's where a lot of the funding is going. It's why our co-responder program has been decreasing funding from the Office of Behavioral Health, because they're funding these other programs. SAFI is expected to be on scene within 60 minutes.
Oh,
60 minutes.
that seems like a very long time.
Right. And that's a mobile community-based crisis response that covers a region that I'm hearing is that there's some barriers to that. But that is another resource that is available to Englewood Police Department, but the time is a big challenge.
Yeah, that seems like a very long time to wait for any kind of aid. Even if you have officers already on the scene, if they're waiting an hour for someone to get there, you know, that seems like a really long time.
Right.
And then I did have one other question regarding what you guys currently do. So we currently have you contracted for 80 hours a week. Is that one co-responder during that 80 hours? Not as in, is there only a single person that serves Englewood, but is it like one person that's working a 40-hour shift and one person that's working a 40-hour shift? How many co-responders do we have available to us during that 80-hour period?
Yep. Great question. And we have 2 full-time co-responders. Each of them works 40 hours a week. And then we also have a case manager who works out of
Just
What,
We have,
what's that?
we have one full-time person, and then we have two 20-hour people dedicated to us. So Katie and Emily, we share. So we have two full-time equivalents, but we actually have 3 people filling that. That's the
Gotcha.
way that that works. And
Plus the case manager, plus the supervisor. And one of the reasons why we have had to, it's very hard if you only have one person, because
Oh, yeah,
then
yeah,
if
yeah.
the person's out, you don't have, we've really learned some lessons over the year in terms of PTO and sick leave and things like that. So the idea, we, as an organization, we have a total of 12 people who do co-response. And so we really do try and find cross coverage as much as possible. And yet it's really important to have relationships with the individual police departments. When we interview, we try and make sure that that each police department is involved in the final interview process. And so that's something that we've had to really pay attention to, because who you hire makes a huge difference in the effectiveness of the program.
Right. Yeah. And is there overlap between their shifts, or are they on completely separate shifts?
Yeah. Reed, do you want to take that one?
sure, John, you probably missed the slide because it looks like you're working on your phone.
Yeah, I apologize. Yeah.
Yeah, you'll get this information. You can look up there. There are overlap days, 2 days a week for them. We did that originally thinking about the school, and we're talking about where we're going with that, and reevaluating that, looking at all the data from both sides about when do we really need to deploy these people, because we are, it's 80 hours a week maximum. And really there's many times during the day when our call load wouldn't support any kind of programming of any sort beyond like a 911 call diversion. And I just wanted to clarify, John, before you get off, the SAFI response, a lot of that would come out of 911 call diversion as well. So potentially that person could be on the phone with the crisis center waiting someone to come, or these are people that can get stabilized and wait until the people can come and work with them to just get them a little more solid base and resourced.
Gotcha. And so you're saying there's certain times of the day and or week where it doesn't make sense to have co-responders. Are there also certain times of the day and or week where it would make sense to have more than one person available beyond those 2 days where there's the overlap that you had already indicated?
No, we really don't think so. The 80 hours we have is really, like I said in the beginning, I'm not sure if you were here, really robust, in terms of staffing for our city. And sure, we could use one sometimes at midnight and 2 in the morning, but most of our call volume, our heavy call volume, occurs sometime late morning to early evening, 10, 11 in the morning till 7 or 8 in the evenings, where we really see the peak of our calls and needs. And it's why we're talking about having, what other resources can we have, like utilizing SAFI and the 911 call diversion program, so that we have 24/7 things in place to deal with this the best we can.
That makes sense. Awesome. Thank you, guys. And I apologize that I do have to leave early. Thank you all for being here. And I will definitely get caught up and send notes over probably in the next day or two. So thanks again for being accommodating of me. I appreciate it.
Yep. Thanks, John. Thanks, John. Okay, I'm going to keep going so that we can get through some of the key points. This is a little bit about what sort of outcomes we know we will have based on different program models that are used. You can see, generally speaking, the outcomes are very similar from one type of program model to the next. One of the differences, though, is that when a co-responder is involved and on scene, we do see that there's a reduction in the use of force. And those are the things that concern me when I think of incidents where we have had people, especially people of color, where force has been used, and it really was because of a mental health or a substance use emergency. So there is some evidence that shows that when a co-responder is involved, that the likelihood of use of force is much lower. I'm gonna go through some of these last ones pretty quickly so that we can open up the discussion. I realize I'm taking a lot of time, but I feel like that this helps make sure we get questions answered. The outcomes for the CIT program, that's that specialized response. That's the one that I mentioned, that ultimately CIT trained officers have the highest number of positive outcomes associated with what they're doing. So I just wanted to show that up there. There is some qualitative research in addition to the quantitative work that shows that police-citizen relationships and the quality of interactions between police and people experiencing a mental health crisis, no surprise, are significantly improved when you're using any sort of mental health professional to be involved in the call. That's kind of a no-brainer, but just want to mention it is out there. A couple other things I want the group to consider are partnerships. So it is important to know that there are partnerships that are either in progress, that already exist, or that could be created around interventions as alternative policing models. What we don't want is for law enforcement to be doing this work. And so being able to partner with someone is always an option. There's a pilot that's starting with Falk Ambulance and All Health, where Falk will be called to the field, to the scene, to do medical clearance so that the person can get directly admitted to an acute treatment unit or a crisis stabilization unit so that they don't have to go, they bypass the emergency department, they bypass the WIC, but they'll be able to get directly admitted. That's a huge win to be able to do that. That pilot is starting soon. In Douglas County, they are partnered with Dispatch Health for the same thing. And so I don't know how they're paying for that, but Dispatch Health goes out and they have a medical provider, a physician who does medical clearance and then clears the person for a direct admit. With the pilot with Falk is being paid for out of the crisis system dollars. And so that's something that is kind of coming to the community soon. One of the key principles of any co-responder program is really the ability to coordinate care. If we can't get people connected with care, they will continue to call, continue to have emergencies. And so that care coordination is very important. It is one of the reasons why each of the different co-responder programs tends to partner with a large community behavioral health organization like All Health to make sure that people get access to care. Community mental health centers around the state of Colorado have access requirements. We are required to get someone connected to services within 3 days if they're seeking substance use treatment, or 7 days if they're seeking mental health treatment. That ability to get somebody connected fairly quickly is really key and is one of the reasons why I am going to continue to recommend that you contract with a community behavioral health provider as opposed to someone who only comes in and does the crisis work, because how are they going to get them connected to care if they don't know the intake process, if they don't have access to all those wraparound resources? Some models of co-responder programs, and you heard me mention this, will allow for the co-responder, the provider, the clinician will transport the client. Transportation is one of the things that helps reduce the burden on law enforcement. So one of the other programs that I mentioned, the car that our co-responders drive, it's through the law enforcement entity, and it has a cage in the car. The individual gets cleared by law enforcement before they can get in the car, and then the co-responder takes them off on their merry way with where they need to go. And so I just want to put that out there, that there are partnerships where these types of things can be arranged, because sometimes it's the transportation, getting somebody from point A to point B, that is one of the biggest challenges. You heard Reed mention at the very beginning, co-responder programs are funded all different ways. And I believe I asked this group early on, like, when we're making recommendations, are we considering funding? How does this play out? And I specifically remember Councilwoman Wink saying something about how we get to be able to make these recommendations. We'll think through the funding at a later time, but that shouldn't bar us from making recommendations. It is very common for cities to pay for at least partial costs with co-responder programs. Grants and foundations have caused programs like the STAR program to launch and have been fantastic. Same thing happened in Tucson. They launched a co-responder program. It was grant funded and it closed. So you have to be very careful about the funding stream. You've heard me mention about the Office of Behavioral Health. They're a partner that we work with. They help fund a lot of services for people who have no funding and people who are living 300% or below the federal poverty line. The Office of Behavioral Health separates funding for co-responder programs from the crisis system. So we've seen a lot of funding being diverted away from co-responder programs and instead invested in respite and the Colorado Crisis Line and crisis stabilization units. And so there's been really a shift. Some communities have passed changed tax revenue, will collect tax revenue from citizens, just like you would for library expenses. There are also programs that will collect taxes. That was a big push in Larimer County. They are funding a brand new all-inclusive center that will include detox as well. That's through tax funding. So it took about 9 years for them to convince the public. It was on the ballot 3 different times, but they finally got it. And now it's under construction. So it does happen. I am a big believer that everyone should be, all the payers should be paying for these services. So I am looking at a proposal that would go through healthcare policy and finance and our Medicaid payer, which is Colorado Access. I think that they should pay for co-responder programs. Every time that an individual goes to the emergency department, it's $2,500. Every time that a co-responder gets them to our walk-in center, it's $500. That's $2,000 just for one person. So I think there's some opportunities there to be able to look at Medicaid. And then there are times also that Medicaid will reimburse for services that we deliver in the field. So if we have enough information, we can do that. Some of the barriers to reimbursement, though, I just want to make sure that you all understand a little bit about the landscape with this. Ambulances that come out to do medical clearance and don't transport do not get paid by the payer. There are individual contracts that people will arrange. So Denver Health may contract Falk Ambulance, you heard me say, but they're getting paid by somebody. Generally speaking, though, if an ambulance is called and if they don't transport someone to an emergency department, they don't get paid. So if they can't transport to our walk-in center because they don't get paid. Commercial insurance, Humana, Blue Cross Blue Shield do not pay for this work. So if we do a mental health evaluation in the field with someone who has Blue Cross Blue Shield, we are unable to get reimbursed for that. Medicaid will pay for it, but not commercial. The other thing that's problematic is that behavioral health providers are paid now on what's called a fee-for-service model, which is essentially tit for tat. If I deliver a service, I get paid just for that service. The way that we staff and generally speaking have to operate a co-responder program, it's a firehouse model that you need to always have someone available. Well, all that time that they're sitting around waiting for a call, we don't get paid. So the only thing that we can collect payment on is when we go out, do a mental health evaluation, have enough demographic information to be able to bill, and it's Medicaid that we get paid for that. So I think that's important to understand. You've heard me mention this a couple times. A lot of times we don't have enough information to be able to bill the payer. 43% of Englewood clients that have been seen by our co-responders were covered by Medicaid. And of that 43%, 98% of the time we do collect Medicaid payment on it. but that only accounts for a small portion of coverage. And I did confirm with the STAR program, the person who runs that program, they have a 60% reimbursement rate for Medicaid, but they have a higher number of people who are covered by Medicaid. So even the financial system is a little bit different for them. And then the last thing I want to mention is that there has been increased competition for funding with the crisis system. The Colorado crisis system does fund the hotline, all of these different places that you heard me mention. However, they also cover mobile crisis teams. And that's the one that if mobile crisis teams have to be dispatched by the Colorado Crisis Hotline. Law enforcement who wants to dispatch a mobile crisis team has to call the Colorado Crisis Hotline, who then calls SAFI, and SAFI has 60 minutes to respond. So that's the only way that law enforcement can get through. And these are, oh, by the way, completely covered by the Office of Behavioral Health. In their contract, I met with somebody who negotiates their contracts because I wanted to find out. I'm like, why is law enforcement? What are all the barriers? They are required to give priority when law enforcement calls and requests a mobile crisis evaluator, but they have 60 minutes to do it. And throughout the entire region, which is pretty big, it's both Arapahoe and Douglas County, they're currently averaging 40 calls a month. And almost, I think like 0 of those calls are with Englewood. So here are some thoughts. And I will leave these up there, and maybe Reed, if you want to talk a little bit about them, we'll open it up for discussion, because this is really where we want to get to. Now that you've heard the whole story, understand the picture, know what some of the options are. I really think that the current model of having 80 hours of co-responder time is meeting the need of the city of Englewood as far as addressing mental health, substance use crises. I think there's some opportunities to be able to change their job description a little bit. As a leader, I have concerns about what my people are doing during their off time. I would like for them to do more case management. I think that they have time and space to be more proactive in their outreach, but that's not the job that they were hired for. They were hired for mental health evaluations. And so in their mind, that's the bulk of what they do. I think there's an opportunity to switch that at no extra cost, and that it would be able to get more people covered. I think that the care navigation, the follow-up, the resources, being more proactive is an opportunity. I think we might have an opportunity for Englewood to partner with a community-based organization that could do more of the case management associated with people who are homeless. That's another opportunity, again, to look at how a partnership can help offset. And I think we need to continue to dig into some of the issues that are happening with SAFI for the mobile crisis response, to see if we can use that resource, which is paid for and available. We just have to make sure that it works. In the future, because I don't think that this is something we can do short term, but I do think that within the next year or two, I would love to see Englewood be a pilot and a leader in determining how to intervene at the 911 level. I think there's some real opportunities there. Reed, what else anything you'd add or clarify on this slide?
I think the only thing I wanted to hit on this slide really was that we, within a month, are going to be on a whole new records management system that we've been working on for a couple of years, and that should enhance our ability to get more officers to make CIT referrals, make the referrals to all healths, which should grant more case management follow-up and more potential field follow-up. When officers make referrals at 2 o'clock in the morning, the next day or within the next couple of days, depending on the days, the case manager at all health attempts to reach out to the people, and depending on the situation, if they can't get a hold of them, they kick it back to one of our co-responders. One of our co-responders and officer go out and try to make contact with this person, particularly if they're homeless or otherwise difficult to contact. So that new records management system should enhance. I expect to see an increase in our referrals and in our caseload, and also with our co-responders, we're going to be expecting them to be in that program more to look for things that are missed. So if an officer really isn't cued into this is really a mental health problem, or if they just flat didn't check the box they should have checked, that the co-responders and case management will hopefully catch that, which really should enhance the way we're delivering services and what we're doing. And I just want to mention there's a study out there which we don't have, but with the follow-ups that we do when we make these referrals, when we hospitalize someone, there's a study or two that say that suicide rate goes down considerably when there's follow-up by mental health within a few days of a hospital discharge. So that's been important to us, and that's been something that All Health has been doing with the case management. So I think that's everything on here, and I'm certainly interested to hear what people say. And Amy with the social work program and professorship, I'm sure has more ideas or questions on this, and everybody else as well.
Well, you got a couple hands raised, Mike and Joe.
Yeah, just a quick follow-up question on the reimbursements. Just help me understand, is that reimbursement for services rendered after a co-responder connects with a client? Or would those be reimbursements that would offset the, I think it was like 132,000 cost for the program itself? Like, is that reimbursement for costs above and beyond that, or would those reimbursements eat away at the 130,000?
The 132 is what Englewood pays for the co-responder time. The reimbursements are to try and cover some of those costs. That is though for both in the field as well as case management time. So if I understood you correctly, it could be for both primary or secondary response. So it could be the mental health evaluation in the field, or it could be the follow-up case management if it meets billable criteria.
Okay, so that 132,000 then does cover that case management additional services. Some of those are lumped in that number right now.
Our program, all of our co-responder programs operate either at a loss or they break even. So last year combined, our co-responder programs operated a loss of $180,000. That's across all programs. So even when we collect revenue, the cost for operating, staffing, running overhead, you don't think they have overhead, but there's a supervisor, program manager, things like that. And so we are pretty aggressive in trying to get revenue because we're trying to offset that. So I don't want to give a false impression that the 132 plus the 30 we get from OBH, that still doesn't cover all of our program expenses.
Gotcha. So that 182,000 then would be costs that All Health would accrue, or
yes,
take on.
yes, and we, some years our goal is really to break even. So the year prior to that, we broke even. I don't have a good handle on. I think part of that was that OBH cut so much of the funding that we were able to break even before because OBH gave us more money, and then starting last year they cut it dramatically. And so
Gotcha.
we didn't stop doing co-response.
Gotcha.
So.
Thank you. The only other thing I'll say is I really get excited about, especially that first recommendation. It makes complete sense to me that using some of the downtime of the co-responders we have right now to a more productive use in terms of case management or care navigation. I think that's a great idea.
Great.
Thanks. I think we've got Joe, Nate, Guillermo, and Dylan lined up.
Thanks. Yeah, a few questions. A quick follow-up to Mike's, thinking about that funding piece. I guess the cost that you All Health accrues are those $500 visits to the crisis intervention and those kind of things are all then charged back to the program, at least in your accounting, so you don't get paid for those, but that's where the losses are and those kind of things? Is that, or
Nope,
where are the losses at?
that's a totally different program.
Okay.
So that's a totally different program. And that program is paid through the crisis system. So co-responder programs, they're their own reporting unit for us. And so like I mentioned, we have 12 different people. We have we have a manager who oversees that program. We have an executive director who is the leader of that program. We have training, we have PTO, all of those, and then they're fully benefited. We also give them a differential because they get paid more because of the work that they're doing than some of our other staff. So their salaries are actually higher. And then obviously they have full benefits. So,
okay.
Yeah.
That's
So
helpful.
it's almost entirely staffing expenses,
Staffing,
benefit,
overhead. Yeah.
overhead. Mm-hmm.
Right.
Yep.
Okay. A couple of questions on those recommendations. One was you said retain or expand it was I don't remember the slide on the slide. There was an 8 hour a week portion for something. Remind me about what that is and
management. Yeah. So part of the contract, and Reed, maybe you can speak of the contract details, but part of the contract detail does include case manager for secondary response. So not the co-responders doing that work, but someone on the back end that works out of our office who takes all those CIT referrals. And so as you heard Reed mention, if the records management, with the new records management system, the hope is that more officers will check the box for a CIT referral. And so we'd like to do more of that follow-up. And so if we can do that, then we would need more than that extra 8 hours.
Okay.
Cynthia, can you share that slide again, just so we can see the recommendation slide?
Yeah.
Mm-hmm.
Yeah, I have a couple of more questions on that, so it'd be helpful for me to see as well. Okay, so the next one, partner with a community-based organization for additional support. Can you expand on that? What would you envision that looking like?
Yeah, and just for the record, I think that I don't necessarily know that we can do all of these things. I think these are all some recommendations to consider.
Sure.
There are community-based organizations that only do homeless outreach. They help people get housed. They employ case managers full-time, care navigators, housing specialists. And so we are a behavioral health provider. And so our strength is mental health and substance use. Many of those folks also need housing services, and they may be experiencing homelessness, but there are other organizations that just do homeless outreach. And so whether that's with All Health or with another organization, it's possible that Englewood could partner with another organization to provide that outreach for the homeless.
Okay. And then the last one is for the future. You're not particularly recommending this right now, but as something to think about in the future, the intervention at the 911 level. Is that specifically you're referring not to dispatching someone, but to transferring those calls or dealing with kind of on the phone dealing with those crisis response, or are you suggesting an actual intervention that does involve the police department at the 911 level?
I would love to see some of those 911 calls be handled by the Colorado Crisis Hotline, who dispatches SAFI, which means that a police officer never gets dispatched.
Right.
Reed, do you want to talk a little bit about some of your thoughts and ideas about this one?
This is something we've been working on for several months now, and trying to explore, and really got hung up a little bit in COVID with trying to have meetings and stuff. But we feel that there's a good potential for this program to really get people in the right place and the right, avoiding the potential for law enforcement contact when it's not needed. When someone calls 911 and says, I'm feeling a little suicidal, the police officers aren't the best ones to deal with it. We certainly will when we need to, and there are certainly situations, and we have run this through our legal team too, to determine, if this is a good option, and they feel like this is a very, very safe and smart thing to do. I think Alex has potentially on here as well. And he said, this is a great idea and you should do it because it reduces our liability while providing people with the best level of services. So we certainly are interested in exploring this and feel that the relationship between SAFI and the Colorado Crisis call diversion is a healthy and helpful one. And there are many people that could be served by it. And the beauty of it is that there's no additional cost to the city. There certainly are ways, if we wanted to spend a lot of money, we could get a dedicated phone line for it. We could contract with Colorado Crisis Services to have specific people answer, these calls, so we could have a quicker handoff from our 911 center. But those are all things that aren't necessary to make this happen, and it can be done, without additional burden on the taxpayers.
Good. So just as a final comment, I like all these recommendations. I'd love all these to be on our list of recommendations going to City Council as a whole. And I'd add on to that, the making sure that we, and this was kind of jumping back to the training discussion, but making sure that we are all, always up to date on the CIT training for our officers, to, have the best CIT training for our officers of any department around. That sounds just like a tremendous way to make sure that we're keeping our use of force limited, is just having that CIT training. So with that, I'll pass it off to the next person. Thank you.
Nate, I think you're up.
Everybody, I haven't spoken much during these meetings, but I think this is where this is most relevant for me. And I guess I just want to say I love the 911 recommendation at the end. The perspective I bring is that of a foster parent to a 10-year-old boy who was at the YMCA, tried to run away because of an incident, and it resulted in the police being called. It was Sheridan, and it was handled as well as could be. But my point is, from the perspective of the caller, many people, we all know 911. We all know that number when things get beyond your control and you feel unsafe. 911 is the number we go to. What I would have liked to have seen in my foster son's case is maybe we don't call 911. I don't think that's going to happen. They train us. We sit down with therapists who describe our home safety plan, which culminates in calling 911 if we feel unsafe. I'm sure the YMCA policy is to call 911. So I like this in particular because I can imagine the call going, I've got a 10-year-old, he's upset and he doesn't want to talk to anybody and he's walking away. And rather than 2 police officers arriving at the scene, followed by an ambulance, asking me if he should be sedated while he was strapped down in the ambulance, I've had a better luck to myself following him on my bicycle as he's threatened to run away from home. I can only imagine a 911 dispatcher saying, okay, 10, maybe there's a history of this sort of behavior. We just are going to kick that right over to SAFI or whoever it should be. So I guess that's all I have to add. All the recommendations, I second what Joe said. All these recommendations sound good. I think it's about sending the best people to do the job and not sending police to do a job that, their time is better spent elsewhere. But this 911 thing seems very compelling to me because, like Reed said, low cost. And then again, from the perspective of the caller, I don't see their suggestions to us changing, right? 911 is always going to be there. Even though I'd like to call a different number, 911 is going to be there. So if 911 could help route it the right way, I think that'd be awesome. So I don't know if there's any more to add. Reed did a great job speaking to it, but I just really like that suggestion.
Thank you so much, because I think that the experience that a parent has when they have a child who is experiencing an episode is exactly a great example. We heard Reed mention this about schools. You don't want police coming on scene. It will escalate the situation, especially with a child. So it's very important for our country to be able to figure out how to make sure that 911 with law enforcement isn't the default. There are many times, and I was looking through the survey data that the Englewood Police Department officers took of what percentage of the time do you think an officer needs? When is it, and family discord or a situation with a child was one of the reasons where they really felt like it's not a good idea for law enforcement. But I would tell you that the same thing happens with it's someone who's homeless or someone who is experiencing a psychotic episode, someone who is saying that they want to hurt themselves, someone who's intoxicated. They see the uniform and it escalates them. And that officer is at a disadvantage from the get-go because of they can be extremely well trained. They can be a phenomenal officer as far as what they do. But for an individual whose brain is operating with the amygdala, they can't think clearly. And all they see is an officer coming at them with you know, it changes the dynamic of the whole situation. So I just really want to echo your experience, Nate. And I promise you, we are getting there. And there's ways we can move it faster than, because 988 is going to be a while. So there are opportunities here to be able to move that faster.
I just want to add 2 more sentences. Your passion's there, and I love that. What Cynthia just said is valid. The police will come. There is zero question that will escalate the issue because of the trauma some of these people have experienced. Like, I can only imagine a sliver where I pass a cop and I sort of get heightened in my car that when they see a uniform, not even flashing lights, much less flashing lights following them with an ambulance coming at them, it did not end well. And it involves things officers shouldn't have to go through, being spat at, being hidden, stuff that, you know, are unexcusable. And then we have to process at home. But the point I want to make is that it sets them up for feeling like criminals. And I know youth are maybe a fraction of who we're talking about serving here, but when they come back home and I have this in heart to heart about how that was for him, and he feels like I didn't think I did anything criminal. Why am I being treated like a criminal? I feel like we get into this cycle of producing criminals, or producing and normalizing that, you know, the cops are the bad guys and you're the bad guy, you're the criminal. So again, thank you, and I love this. Any alternatives to policing? Police should not have to deal with being, you know, spat in their face. You know, that's just not cool. Thank you. I'm good.
Thanks. And I just I'm going to do a quick time check with everyone here. I think we've got about 30 minutes left, 28 minutes left. And we've got Guillermo, Dylan, Amy, Donna, and Mike. Guillermo, you're up.
All right. Thank you, John. Cynthia, first off, thank you. Great information. And I'm like 100% aligned with the recommendations. My question for the group is, as a task force, what's our responsibility here? Are we voting, or are we making the recommendation for the service, or are we making a recommendation on the vendor? And if knowing that there is an RFP out, are we going to see that as well in their recommendation so we can compare and contrast? I don't know who would be the ones to answer that.
I'm doing the RFP, so I can probably answer that. And I certainly will take your recommendations here, RFPs and bids. And this is a bit out of my ballpark, so if the deputy chief wants to jump in, he can. But we don't necessarily go with the lowest bidder. We go with the best that meets overall. We look at all the criteria. So if the group wants to make a recommendation, we are certainly here to listen to that. And my boss, Chad Reed, and his boss, Sam Watson, we're all in this. John Collins will be in that decision-making process, and probably Sean Lewis as well. Ultimately, it goes to council for approval because it's a contract of over $100,000 as well. So that's how the RFP and process works. But we'd love to, hear your input on that.
Wonderful, thank you. And I guess my recommendation would be to schedule some time to see the RFP or have a plan as to when we could discuss it.
Yeah, I just finished the final draft with the city attorney yesterday, and so Sean Lewis is listening to this meeting, and he said, he's given me some notes already on it to deal with it. So we will make sure that it includes the things that you want it to include, which I think it does. I think it's global enough that we can hit this, and Cynthia's seen a draft of it as well, although the draft has been changed some, but we definitely will be on top of that.
Wonderful, thank you, Reed.
Dylan, you're up.
John, I'll go ahead and yield my time. I think a lot of my task force mates covered the items that I wanted to cover. Just thank you, Cynthia, for the very comprehensive presentation. I think this was very valuable information, and I'm happy to see that we have such a best practice in Englewood to protect everybody. So thank you.
All right. Thank you, Dylan. Amy. All right, Amy, now Donna.
Oh, sorry, I was on mute.
Oh, you did hit something. Okay, yeah. So go ahead, Amy.
Sorry, yes, I was just praising Cynthia and saying these were amazing resources, and I was like, who wrote all of these amazing things? And so you and your team did a great job. So I appreciate all the information. A few points. I think partnering with the CBO on homelessness is a great idea. I don't think it'll be any additional cost to anyone, right? Because it's really about partnership and communication. So I think that is definitely something we should consider. I wanted to ask about the expansion of the case management. How do we get to the understanding that they have downtime, right? Because I feel like they are in situations that are in crises and escalation. So having downtime for them to decompress and dealing with the trauma they might have encountered may be important. So I'm not sure how we know that they have downtime. So I just want to make sure, like, before we make a recommendation, that's something that we talk with current staff or previous staff about.
Yeah, that's a fair question. Number one, I'm glad you like the resources because I was aiming them for you and Paul, right? I knew you guys were going to read through them. So thank you. And I think that, the average number of interactions that the co-responders have throughout the entire time that they're working on a given day is 3. In community mental health, even with our assertive community treatment team, which they do some pretty intensive outreach, they typically they have 5 interactions a day. So if I can have the co-responders that are doing, say, 3, they're still doing the 3 interactions a day like they normally do, which have to do with mental health. But if they can add even 2 case management contacts, or let's even take it down and say just 1, that it's expected of them, that they would do an additional 1, I think we'll get a lot of value add out of that. And I do believe, based on my conversations with Reed and knowing the co-responders, that these are folks that have a very good work ethic. I don't want them to be bored. I don't want them to be waiting for a call. I want to keep them busy. I think that helps reduce turnover. And so, yes, they need time to decompress and to transition from one to the other. But at our walk-in center, when folks are dealing with uncontrolled crisis in a situation, they often have more than 3 a day. So I think it's very possible that they could do follow-up. The thing that we have to work out is that we also want to make sure that they're available at the drop of a dime. And so it's one thing if they're working in the office and if they're at the police department and they can pick up the phone, and if they're doing telephonic case management, that's fine. You can drop that and still be available to go out on a call. It's a little different to do the outreach. So we may need to relook at the schedule to say, okay, if there's 2 co-responders that are working at the same time, one of them is doing their case management hours during that time, and the other one is available for co-response. So that is one of the recommendations that I think Reed and I need to work out to figure out when we look at this schedule, how can we use the existing schedule we have to shift it so that there's more case management time?
Thank you. And I can connect with you outside of this, but I think having social work interns to work with your staff, that is something that totally the graduate school of social work would love to do. So, but my final question is regarding the survey, because I read through all of them, like Cynthia said, and I wanted to ask Reed and maybe Chad, who's on the call, I think regarding, like, are there things from that we took into account as we are making recommendations of what they think is needed in terms of the co-responder program? Like, do we have a chance to take that into account, the open-ended responses? Because I think people said about paperwork, like, that didn't really help with their paperwork. They still have to go out, so their workload is the same. And so I just wanted to ask if that was accounted for.
You know, with these recommendations, this is really Cynthia and I working together, and I read through a number of those surveys. I have not, unfortunately, read all of them. Everything we're doing is trying to reduce the interaction of law enforcement when feasible with people suffering from substance abuse disorders and serious mental health, and to some extent homelessness too. So I think we have an eye on that. Our biggest eye though is on providing the best services we can for the community, because I think that's, as a police department, that's what we have valued for as long as I've been here, and especially in recent administrations. It's really providing high quality service to the citizens and looking at what's best for them. Does that answer your question, Amy?
And I appreciate your comment. I think is that more around, for me, it's more the heart of the matter that we're making these decisions and adding to these programs, but the people who are going out, right, are still your officers and their interaction with the community. So I just want to make sure like the things that we're doing also represent something that they want to happen. And I agree that primarily our job here is to protect and serve our community, but at the same time, we also want to make sure that the needs of our officers are being met so that they can do the best that they can, right? So I just, some of the things they said, they were hard things to read, right? And so I wanted just to see if we can look into that and make sure that those needs also, if it relates to these recommendations, can be incorporated.
Yeah, and they're very excited about 911 call diversion. Every single one I've talked to thinks that's a great idea. Anytime that we can reduce our having to respond to things that we don't need to be doing and actually, focus on criminal events. Our department's really taken a stance on trying to intervene in criminal situations and really redone the way we've approached things in the last several years under Chief Collins. So I think they're excited about that, and anything that we can. They love the co-responder program. When this came into being, I was thinking, I'm not sure how this is going to go over, because this isn't something that traditionally has worked. And I would say that 99 out of 100 officers, and that's more officers than we have, support the program, believe in it, and see the value of it, and think that it helps them in their day-to-day jobs. So everything that we're doing, has an eye on reducing calls for service and reducing police interactions. So I hope that helps them. And I'll look further into this, and we'll definitely be looking closer at all.
Thank you. That's all I have.
Okay, Donna, thank you for your patience.
Sure. First of all, Cynthia, it was great to see your presentation. You answered a lot of the questions that I had coming into this meeting. I go along with all these recommendations that you have. I think they're great. Piggybacking on Nate, the Denver Post had an excellent section in their paper on Sunday regarding mental illness within teens and how much they are traumatized when police officers show up at their home. For whatever reason it is, they're scared. It makes them scared, and they're also embarrassed to have friends or neighbors see a police officer show up at their house. So I definitely think that the co-responder program within our teen community that's having mental illness, that provides a different atmosphere for these kids, rather than a person showing up with a gun, with the uniform on, makes a huge difference. So that's all I have to say.
I appreciate that. There are Douglas County, as you may know, and I haven't seen that article, but they have a youth co-responder team that they have implemented, and it is paired with law enforcement, and at times the co-responder is also wearing a police uniform. They have a slightly different shirt, and so it's something Reed and I have talked a lot about, and we'll both compromise over how this works. But most of our co-responders are female. They do dress in safe clothing. but the idea is that they're still identified as a mental health professional. And I think that part is extremely important. So thank you for mentioning it, because the whole idea of trauma is very, very real. And there's a lot of things that if we traumatize someone now, they're more likely to have more and more problems in the future. So with teens, every single intervention is essentially a prevention of something for the future. So thanks, Donna.
Mike, you are up.
Thank you. Yeah, I appreciate everything that's being said as well. I think this has been a really productive conversation. I wanted to circle back just once more, hopefully to just put a bow on the topic of CIT training. I know we had talked about that. I think Joe mentioned maybe putting a recommendation for looking into that training more universally. But I just wanted to ask maybe Reed or Chad, what percentage of Englewood officers right now have CIT training? Is it a policy that all officers have that training, or what's the status of that?
It's not in policy, but it's close to 80%. We try to make a point to get everybody through. Unfortunately, this year, all training has been shut down due to COVID. So the folks that put on the CIT courses are not training currently. It's a 40-hour class. So as soon as that gets back up and running, anybody that we can identify that has not been through the 40-hour course will get through it.
Okay. So the goal is to have 100% of the police force have gone through that training.
Absolutely.
I think with our new building, we can actually host a course here. So I'm going to work with Chad and the people at All Health to see if we can make that a reality when we can lift some of the restrictions with COVID coming up in the next months.
Okay.
Yeah, and I apologize. I didn't put that recommendation on here because I assumed it was a given, right? It really should have been the first recommendation on here, but that's an oversight on my part. But I think that this group is very much on the same page, as including the department.
Yeah, I think it would be a great recommendation, kind of low-hanging fruit to say 100% CIT trained of the police force. That's all from me.
All right. Thank you. Paul.
So let me apologize. Some of my COVID coworkers are having a meltdown at bedtime. And so there's some crying going on in the background. No need for crisis intervention, but some crying in the background. So I just want to applaud what's happening in Englewood. With the information that was sent out, the presentation tonight, I'm blown away and very, very impressed. And to have the recommendations from people who are actually engaged in the work, I think that's tremendously valuable, and obviously support everything that's been put out. I think Amy makes a good point about that qualitative data coming in from frontline workers who are engaged in this. And I think the hard data, the statistics are important that obviously you're collecting and continuing to collect. But I think having a mechanism to engage and continuing to engage that qualitative data from frontline workers to understand how it's working and recommendations for improvement in an ongoing way is one way to keep that aspect of the police department kind of a living and learning organism that is adaptable to the community. So I think Amy brought up a really, really important point, and possibly something to add to the recommendations is just a mechanism for collecting that qualitative feedback from the frontline people.
Maybe a program evaluation as part of the RFP.
Possibly, or even more, it could be even less formal, maybe a learning team type approach where every once in a while we're collecting that qualitative data about what's going right, what's not going right, and how we can improve the process, given how influx different aspects of the community can be at different times. But that would be the only addition to absolutely amazing recommendations, and it sounds like an amazing ongoing program.
Joe.
I just had one last thing I wanted to say, just to our police officers and sergeants and commanders that are on the call. Like, I know we've been doing this now for this is the 4th week, and it's a time where a lot of our people in police service are struggling with how they're seen in the community and all that kind of thing. And then on top of that, I feel like you have this meeting where we're sitting here critiquing everything. And I just want to say I'm blown away by the quality of our police department, the quality of the training and the co-responder program we have. You guys are awesome. And to hopefully just to counter some of the we're nitpicking sometimes. Maybe it feels like we're nitpicking or something, or finding the problems with what you guys are doing. If they're, but I see just very little that our police department is doing wrong. If we get through this process and we can improve it just a little bit, that'll be a huge win, because you guys are already in such a good position. And with the All Health Network putting so much work into this as well, and funding so much of it, I'm really blown away and really, really thankful for the police department we have. So I just wanted to make sure I got that comment in.
All right. Well, thanks for that, Joe. Any other thoughts, I guess, here around recommendations? I think we've got this list here, as well as a couple of additional ones, one around the 100%. Oh, sorry, Mike, go ahead.
Yeah, I would just be curious, and I would agree with everything Joe said. It's really encouraging. But I'd be curious to hear from the officers on the call as we look at this list of recommendations. I know this was put forth. Cynthia, you mentioned maybe not as a list of recommendations that might all be realistic, but just as things that we can think about. But would all 4 of these bullet points be feasible to accomplish? If we list them as recommendations, would they be within the scope of possibility, or would we pick and choose between the four of them?
Realistically, yes, all of these could be. What I would want to be sure is that they're not duplicative. So for example, if Englewood partners with a community-based organization that specializes in homelessness and does case management, and we have someone do that, then you wouldn't have your co-responders do case management with that population. So those are the types of things. I think the last bullet point related to the use of SAFI is complicated. I would like to make sure, and now that I have a lot of connections on the crisis system, because in my role, I oversee all of those programs as well. So I think there's some opportunities there. And in having conversations with Reed, he and I have learned some things about that I didn't know things were happening on his end. He didn't know things were happening on my end. So yes, I do think that these are all feasible. I would want to make sure that they're not duplicative, that we're good financial stewards of the resources that are coming through, and recognizing that some of these are very easy to do and others are going to take some time and be more complicated. And so we need to be realistic about an implementation timeline, especially with how to intervene at the 911 level.
And Mike, to address your specifically with the partner with the community-based organization, I envision that as someone that would be it change the trend all the time, work with our partner organizations, and really help pull some things together. Change the Trend is a phenomenal organization. And it blows me away how successful it's been, but with a lack of full-time staffing dedicated to it, sometimes pieces just kind of float around, and it would be great if we could have somebody to pull that together, and maybe even that position, maybe it's something different where it's funded by some of our partners. Maybe the city picks up a little bit of it. Cynthia and I have been really careful that there's a budget crisis going on everywhere, and we could have stacked this up and asked for all kinds of things, but these are things that we thought were somewhere within the bounds of realistic and doable, wouldn't be a burden on the people, or potentially even raise the budget at all.
Totally. I totally hear that. And I agree. I think Change the Trend is a good hub of collaboration, but I want to be careful of taking on too many programs that we would run as a network. I think spinning something off might be appropriate, but yeah, I hear you. But yeah, I think all of these recommendations, as I read them, they all seem within the realm of possibility for me. So I just wanted to clear that up.
All right, thank you, Mike. Amy, do you still have a question?
Oh, I'll use my time to Nate.
All right, Nate.
I just want to check if the 911, like, why isn't it a bullet point? Is there a reason it's marked future, and or I'm curious about that independently of, can we make sure it's still in our list of recommendations? It sounds like it got pretty round support in this meeting and was cost effective to boot. But why is it future?
So I would absolutely love to see it be as a bullet point. It's future because I am a realist. There was a pilot that was gaining, there's a separate work group in the state of Colorado that is looking at implementing this. It has been meeting for quite some time. They just got to the point where they had 2 different counties where they were all set to pilot it, and it just got squashed last week. And so my fear is that I don't want to put out a recommendation to this group that is not feasible. There is only one crisis hotline in this. If we're talking about diverting calls to a crisis hotline, there's one crisis hotline. They actually operate the veteran crisis line, the LGBTQIA hotline. They get contracts for all of this other work, and they only have the staff that they have. They do a text line. So this is largely a resource issue. They have to get additional funding in order to be able to accommodate these calls. And that's part of why the pilot crashed. And so the reality of how is this actually going to work? They tend to start up a new program, a new initiative through the Colorado Crisis Hotline. They'll do a few a year where they can man the capacity, have the leadership, be able to hire the people, because it's 24/7. So it's a very difficult workforce for them to hire. And they just said, you know what, we don't have the resources for it last week. So that's the part that I just want. Yes, I think it should be a recommendation. Might need to look at some other opportunities beside the Colorado Crisis Hotline. And that I think this group is primed for it. I think that Englewood is a great place to be able to do a pilot, much smaller than taking on a whole county. And I think there's some real possibilities there, but it's the most complicated of the recommendations.
Thank you.
Okay, Amy.
So real quick, sorry, I know we're running out of time. I want to add the recommendation. I think it speaks to kind of a few weeks ago about Guillermo about branding and policing and community engagement, about our co-responder program as part of the recommendation, so that the YMCA will know about the co-responder program, right? Or call different outlets, or even when they're calling. So I think that's part of, I heard the officers too, like the community needs to take responsibility when we call them, right? And so I think having a recommendation about how do we then promote this program and our alternative responses is going to be key for this to work between EPD and the community.
Yeah, I second that, because that's something I could take away. I put a lot on the 911 call center when I say, oh, I love that they could just handle it. But I feel like I want to go back to the therapist and be like, can we please just put Colorado Crisis Center instead of police? Like that should be first before we even get to police. And the YMCA, like Amy said, this should, let's try to do some outreach so they can divert their own calls, and then we can see the switch naturally happening. So resources get aligned better.
Yeah,
I like that.
and to that point, with if we do move forward with expanding the co-responder job description to include other kind of outreach, is it appropriate at that point to continue to call them co-responders, or does co-response then become a subset of a broader job description under a different brand or title that more accurately encompasses everything that they're responsible for?
Yeah, that's a good point. I think it's something we could look at, and maybe we could sit down, whether it's us or someone else. I think that the job description of whoever is doing this work, it needs to be evaluated. So it's a good opportunity.
Okay. Not seeing any more hands raised. I think then from what I've gathered here is that we've got this set of recommendations. Oh, you just took them away. That's okay. That's okay. Don't worry about it. So we've got those recommendations, and then I think I heard 3 others. So one was the around the qualitative data that Amy mentioned, right, and getting that from the front line, whatever that may look like. Also putting something in, it may not fall here, it may fall in our training discussion, but to get 100% of the police force trained on CIT. And then the last one is just this around making sure that there's a way to promote the available resources once this is kind of finalized to the community. Anything else that I missed? All right, great. Well, this was really good. And Cynthia and Reed and everyone else I know that was involved in this, thank you so much for pulling all this together. I think it really helped facilitate the conversation tonight. So a big thanks for that. And I know that it was a lot of work, but I think that it really helped us out here in the end.
Well, and thank you for the time too. I think that in order to do justice to what we're really trying to talk about, there's a lot of information that needs to be covered. And so I really appreciate you guys giving me this much time.
Sure. And so I guess then my thoughts are then for next week, we're going to continue with part 2. And this kind of is more around homeless services, addiction services, mental health. And then there's also something in here, you know, that's overlap, which is really more cahoots and star kind of conversation. So I think that if we look at this and next week, we kind of can figure out where there's overlap. It may be a little bit more efficient to get us through, because I think Cynthia and Reed have probably done a good job of preparing us for that conversation. And then the last thing though, is we still need to come back to the training discussion. And I don't, you know, I guess Chad, I don't know if we'll have the documents ready, but I'm going to have to get with Ryan or somebody else to make sure we can at least get probably another calendar invite in.
Yeah, so I'm working on a infographic with one of our designers that we contract with through the city. And she's putting that together for me based on information and some stuff that I sent her this week. So as soon as I get that back, I'll get that out to the group.
Okay. All right, great. So we just have kind of, I guess, those 2 last pieces to finish things off before we kind of pull together the final recommendation set to present to City Council. But I think next week, and I'll check with everyone, but at least the second part of the alternate policing discussion may be a little bit shorter. And if Chad has some documents ready, then we may see if we can split the time and go back to the training discussion as well.
And John, one more thing. We also want to maybe make some time next week for Aim Stenson to talk about our restorative practices program that we're looking at implementing, and also Deputy Chief Watson would want to speak to that as well.
All right. And I know Ames is on tonight and didn't really get the chance to talk, and we probably wouldn't have had time. So we'll slot those in for next week as well.
Thank you.
Okay, I think that's it. I'll do the usual thing and send these notes out in the next 24 hours or so, as well as an update for our agenda for next week once I confirm kind of all the supporting documents. And otherwise, have a nice and smoke-free-ish evening.
Thank you.
All. See ya.
Good night, everybody.
Thank you, everyone.
Thank you.